There is a single silent error that countless families make when an elderly loved one begins to decline. It's not a lack of love, and it's not a lack of effort. In fact, it's born from the best of intentions. But this one mistake can trigger a cascade of medical events, accelerate physical and mental decline, and ultimately rob your parent or grandparent of their independence, their health, and even years of their life. This is not dramatic speculation. It is a clinical pattern observed in geriatric medicine. And by the end of this video, you will not only understand exactly what this fatal mistake is, but you will also possess a clear, actionable framework to avoid it. A framework that could very well change the entire trajectory of your loved one's later years. The fatal mistake is this: we treat the symptoms, but we fail to diagnose the system. Let me explain. When an older adult starts to struggle, perhaps they're falling more frequently, they've become confused, they're losing weight, or they're just not themselves. Our instinct is to find a direct, singular cause. We take them to a specialist for the most glaring symptom, the cardiologist for the dizziness, the neurologist for the confusion, the orthopedist for the fall. And each specialist, operating within their silo of expertise, may prescribe a new medication, a new treatment for the problem they see. This is the system-focused approach. But in geriatric medicine, this is often where the problem begins, because the human body over the age of 70 is a complex, interconnected system where a failure in one area is almost always a symptom of a problem in another. The why behind this mistake is rooted in how modern medicine is structured and how we, as families, perceive decline. We are conditioned to look for the broken part to fix. A heart problem gets a stent. A joint problem gets a replacement. This mechanistic view works well for younger, otherwise healthy individuals. But for a senior, a single symptom is rarely just one thing. That fall wasn't just a slip. It was likely the result of a subtle combination of factors. Perhaps a new blood pressure medication causing a slight drop in pressure upon standing, compounded by weakened leg muscles from poor nutrition, and diminished eyesight from a cataract that hasn't been addressed. The confusion isn't necessarily the start of dementia. It could be a urinary tract infection presenting atypically, or it could be a dangerous interaction between 5 different medications prescribed by 3 different doctors, a condition known as polypharmacy. We agitate the problem by not recognizing that frailty is a syndrome in itself. Frailty is a state of increased vulnerability from age-associated declines in reserve and function across multiple organ systems. It means the body has lost its ability to withstand and recover from even minor stressors. A simple infection, a small change in medication, or a minor fall is no longer a small event. It's a catastrophic shock to a system that has no reserves left. When we fail to see this bigger picture, we are essentially putting band-aids on a system that is fundamentally coming undone. We are reacting to crises instead of preventing the cascade that leads to them. This reactive approach leads to hospitalizations, institutionalization, and a profound loss of autonomy. The senior feels passed from doctor to doctor, their concerns fragmented, and their sense of self eroded. The family becomes exhausted, burning out from the constant cycle of crisis management, never feeling like they are getting ahead of the problem. This is the inevitable destination of the symptom-focused approach. The solution is to shift from being reactive problem solvers to proactive system managers. This requires a new lens, a new set of questions, and a specific step-by-step strategy. The core solution is what we in geriatrics call Comprehensive Geriatric Assessment, or CGA. But you don't need to wait for a formal hospital referral to adopt its principles. You can become the conductor of your loved one's healthcare orchestra, ensuring all the sections are playing in harmony. Here is your actionable plan. Step 1 is to initiate a medication reconciliation and review. This is non-negotiable and is the single most impactful step you can take. Polypharmacy, the use of multiple medications where the harms begin to outweigh the benefits, is one of the greatest silent threats to the elderly. You must gather every single pill, supplement, and over-the-counter medication your loved one takes. Put them all in a bag and take them to a single appointment, preferably with a geriatrician or a trusted primary care physician who is willing to take the time. The goal of this appointment is not to add a new drug for a new symptom, but to ask one critical question. Can we stop or reduce any of these? The guiding principle here is a secret known well in geriatric circles but often overlooked in general practice. Start low, go slow. But equally important is, when in doubt, taper out. Many medications that were essential at age 65 may be causing more harm than good at age 85. Blood pressure and diabetes targets, for instance, can and should be relaxed in most older adults to avoid the dangers of overtreatment, such as falls from low blood pressure. This one step alone can resolve issues with confusion, dizziness, fatigue, and loss of appetite. Step 2 is to conduct a functional system audit. Instead of asking, "What disease do you have?" we ask, "What can't you do that you would like to do?" This shifts the focus from pathology to personhood. Break this audit down into key domains. First, mobility and balance. Can they get up from a chair without using their arms? Can they walk across a room without hesitation? Do they feel unsteady? Second, nutrition and hydration. Have they lost weight without trying? Do they have difficulty shopping for food, preparing meals, or chewing and swallowing? Third, sensory health. Have they had their hearing and vision checked recently? Hearing loss, for example, is directly linked to social isolation and cognitive decline. Fourth, cognitive and mental health. Are they more forgetful about recent events? Have they withdrawn from hobbies or social activities? Do they seem sad or anxious? This audit isn't about diagnosing, it's about identifying points of failure in the system of their daily life. Step 3 is to synthesize and strategize. You have now gathered the two most critical data sets: the medication list and the functional audit. It is time to connect the dots. Take these findings to a geriatrician. A geriatrician is a specialist who is trained to look at this exact big picture. They are the quarterbacks of elderly care. They will look at the dizziness, the medication list, and the mobility issues not as separate problems, but as interconnected threads of the same tapestry. They can order tests that a cardiologist might not think of, like a sit-to-stand blood pressure test, or assess for conditions like sarcopenia, the age-related loss of muscle mass that is a primary driver of frailty. The strategy that emerges will be holistic. It may involve deprescribing medications, referring to physical therapy for balance and strength training, arranging for a nutritional consultation, or getting a hearing aid evaluation. The goal is to build resilience back into the system. The secret data point that gives this approach its authority is this: studies consistently show that a comprehensive geriatric assessment, when compared to standard care, significantly reduces the risk of mortality and institutionalization in frail older adults. It doesn't just make people feel better, it objectively extends their functional, independent life. This isn't alternative medicine. It is the highest standard of evidence-based medicine for the complex elderly population. You are not managing diseases. You are managing a person's physiological reserve. You are fortifying the system so it can withstand the inevitable stresses of aging. By focusing on the system, the medication interactions, the functional abilities, the sensory inputs, you prevent the dominoes from falling in the first place. You move from a state of constant crisis to a state of managed stability. This is how you protect their independence. This is how you add life to their years and years to their life. You now possess the knowledge to avoid the single most common and devastating mistake families make. You understand that the symptom is a signal from a complex system, not just a broken part. You have a 3-step plan. Reconcile the medications, conduct a functional audit, and synthesize the findings with a geriatrician. This is the path forward from reactive fear to proactive control. You have the power to change the narrative for your loved one. If you found this deep dive into proactive geriatric care valuable, then you understand the mission of this channel. Senior 24/7 is dedicated to providing expert-level, authoritative information on the most serious challenges in aging. We cut through the noise to give you strategies that are based on clinical evidence, not fear. To ensure you don't miss this critical information for the future, subscribe to the channel and turn on notifications. The journey of caring for an aging loved one is complex, but you don't have to navigate it alone. We are here to provide the clarity you need, and we want to hear from you. What specific challenge are you facing right now? Let us know in the comments below, and your topic could be the focus of a future video.